I think we'll get started. My name is Beth Peters, and I'm the chair of the nursing department at Bethel, and it will be my privilege to introduce Dr. Schaffer. I'm doing that because our provost, David Clark, is not here. He's at the trustee board meeting, and so he sends his regrets, but I shall try to do my best. First of all, especially for those of you that are visitors, let me just explain that Primetime, which is what's happening right now, is Bethel's Library's mission to encourage lifelong learning beyond the classroom. The entire Bethel community is a collaboration of friends at Bethel University Library and many different offices on campus. And then just a reminder for faculty especially that there is a prize going on in terms of the library, and we're encouraged to have our students submit a project or paper that makes extensive use of the library resources such as books, online journals, equipment, services, and so forth. There is a prize of $250, a library research prize for this. The deadline is February 15th, so if you have students that might be interested in that, please encourage them to do that. This is the first Primetime of the semester, and their full schedule. Thursday, Jay Rasmussen's will be talking about our new students learning foundational issues and assessing student learning in the classroom. So keep in tune for other Primetime activities. Now, to introduce Dr. Schaffer. She's been a Bethel faculty member since 1984, and she's the current university professor of nursing. She has done all kinds of things. I have a list here. I'm going to try to highlight it. Then I'm going to tell you some things that aren't on this list because I don't know if they're more interesting. But anyway, she is an author. There's some books up here that are hers. One of them is the President of Nurses Resource for End-of-Life Communication. Another one is Population-Based Public Health Clinical Manual. Both of those, or at least the first one, I don't know if the second one is published by Sigma Theta Tau, which is the Honor Society of Nursing. It's an honor to have it published through them. Marge has had a number of Fulbright opportunities. She is currently a Fulbright Specialist and will be leaving for New Zealand soon. She has been a Fulbright Specialist in Norway and a Fulbright Senior Scholar in Norway as well, and has collaborated with Diadema University there in terms of developing a master's program, some ongoing research projects, partnership between Bethel and Diadema, and so she's been busy in that area as well. She's also served as a liaison between Bethel University and Hopkins Medical Center in terms of doing research, evidence-based practice kinds of issues, which has been very exciting for us because it's allowed us again to have a research partnership with a large medical center in the Twin City area. She's also been involved in developing something that at least nursing students know a great deal about, something called the Public Health Nursing Intervention Wheel, which is a model that actually shows all of the kinds of things that public health nurses do. And it's really received international attention. It's known as the Minnesota model, and there are people around the world who use it and talk about it. That's what David Clark would have said. Now, what I want to say is a couple of other things. First of all, one of the things, Marge has been involved in a number of publications, but one of the things that I think is really important is that if you look at those publications, especially the articles, you will often see that she has done it in conjunction with the students. And I think it's a major, as a university professor, that's a major contribution. As those of us know who've been involved in having our books published, probably doing the first article is the most difficult. And so to have a faculty member who comes along and says, let's do this, is really an important contribution. She played a major role in establishing the graduate program in the nursing department, and her high standards are still part of that program. She's been instrumental in developing the engagement program. She's a person of faith. Her commitment, especially now to some of the end-of-life issues, is a way of maybe bringing that all together. Marge is also a wife, a mother, a grandmother, and I think maybe most important to me and to us in the nursing department is she's so Marge.
Well, thank you all for being here today, and I do want to express some acknowledgments because on this journey to becoming university professor, there are a lot of people that have been on this journey with me. And so in particular, I want to recognize colleagues Linda Olson-Keller and Sue Stroshine for their cutting-edge thinking in bringing public health nursing into the national arena, and for including me in the writing partnerships. And then Kari Govin, my colleague from Norway, who has a vision for international views on public health nursing that I've been privileged to be a part of. And also my mentors, Betty Leah Holberg, who really mentored me in a rigorous writing process. And then Esther Tatley, who is sitting over here in the Norwegian sweater. And Esther was my inspiration for public health nursing way back in 1970 when I had a summer internship in Chisago County, and that's where I learned to love public health nursing. And Esther has continued to champion me through my work and partnerships with Norway. She was very instrumental in helping me to make connections there, and we both share a love of Norwegian heritage. I would also like to acknowledge my husband who couldn't make it today. One of my secrets of my success is that I have a husband who cooks. And so that gives me more time for these scholarly endeavors. And I do the cleaning up, but I do it very fast. I also would like to acknowledge my colleagues in the nursing department and students in the nursing department. And then, of course, my God. These are some, acknowledge my God in my life. These are some key scriptures that have guided me along the way. One is the encouragement that we give to one another in building each other up, and I always try and do that, in my scholarly work. And then we are just blessed by the different gifts that God has given us. How wonderful it is to bring all those different gifts together and make a difference in service to others. And then, of course, Micah 6:8 as my guide. What does the Lord require of you? To act justly and to love mercy, and to walk humbly with your God. And I try to follow that in my work. So I wanted to give you a little bit of an overview of evidence-based nursing practice because that's in the title of my presentation today. And of course, evidence is important in a number of disciplines, but it's really come to nursing, I think, in a major way in the last probably 10 years. It's a problem-solving approach, and it really is about systematically finding the best evidence and appraising it. Is it good evidence? Is it true evidence? And it's in response to trying to answer a question about nursing practice. And so where do we find that? We find it from research, and I've done some research, but I also look at the research of others to find the evidence. There are experts in public health nursing. We look at data about patients. And for public health, this would be like incidence of diseases like Lyme's disease, cardiovascular disease, looking at health problems like family violence. Then, of course, one's own expertise that we learn along the way, and then patient satisfaction. Just briefly, one of the models that we use here at Bethel that I really like for guiding evidence is the Johns Hopkins nursing evidence-based practice model. And it really does follow a problem-solving approach all the way from identifying the population health issue for public health, getting the best evidence, appraising it, what does it mean, and then deciding what are you going to do with it, and then actually disseminating it, trying out, and evaluating it. And a lot of my work involves doing some of that original research and creating that evidence, but some of it also involves disseminating that evidence. So I'll share both those kinds of projects. So why is it important to build an evidence base? Well, one thing that is happening, and we know this is happening across the nation, is we're getting cuts in public health funding. There's simply not enough money to go around. So how does that influence us? We need to know the best evidence. We know where to put the money and get the best results. We also have population changes. The growing elderly population, we have growing minorities and health disparities. We need to deal with those. One thing that's coming on board most recently is accreditation for health departments, just like we have for hospitals and education programs. So we need to use evidence in order to get accreditation. And another issue is the lack of visibility and voice for public health nurses. One of my recent experiences this past October was to be a part of the second International Public Health Nursing Conference. The first was in Norway. And it was just a delight to be a part of that conference. I was on the planning committee to see it come to fruition and have 300 people come internationally, nationally, and locally to learn from experts about public health nursing. It was a time to hear the voices of public health nurses, so that was a very good experience. And then, of course, overall in nursing, we just really need to have evidence-based practice. So I wanted to start out with some of the beginning work that really has opened many doors to me, both with Fulbright and for scholarly work. And the public health intervention wheel was actually developed by Sue Stroschein and Linda Olson-Keller, who were at the Minnesota Department of Health at that time. My role, and my mentor Betty Leah Holberg, our role was to help get it disseminated. So we were kind of mentors with Linda and Sue at that time for writing and getting the article published. And it's been very rewarding. That led to opportunities both in Norway and New Zealand for me, this public health intervention wheel article. And we've been told that these articles get the most hits of any articles in this journal. So we know that it's really out there. And then the second project that I was involved in working on just recently came out as an article, and that's on the cornerstones of public health nursing. Again, this was work that Linda Olson-Keller and Sue Stroschein developed while they were at the health department. It's based on evidence, going through the literature, and then also getting affirmation feedback from expert nurses. And so the whole idea was to come up with the values and beliefs that drive what public health nurses do. What are the foundations for why public health nurses do what they do? So it helps us to articulate what we do. So it brings together both literature and evidence from nursing practice and from public health practice, those two things. And so you can see on the right hand, there is a list of the 8 cornerstones. So we can see that public health nurses are focused on population health, improving health status for population groups. They want to address community priorities and needs, what's most important and needed by that community, and that can vary across communities. Public health nurses are focused on caring relationships. And this is not just caring for individuals or families, but it's creating caring communities. Do you live in a community that you consider to be a caring community? How can we do that? Public health nursing is grounded in social justice. So we want to make sure that everybody has equal access. That's not the case, of course, but we try and remedy that as best we can. And then public health nursing is driven by epidemiological evidence. That looks into all those contributing factors that contribute to disease or health problems, from people, from the environment, from the factors or agents that cause a disease, trying to figure that out. And then I think one really huge one, and my favorite one, is collaboration. We all work together. In public health, we work with many different partners, schools, employers, churches, all sorts of organizations, nonprofits, to really promote better health. And this is my personal favorite. I just love to do that networking and work with groups of people. And then, of course, our authority comes from the Nurse Practice Act. And public health nursing is, by and large, independent practice. On the intervention wheel, there's only one intervention that is delegated functions that comes from orders or something that a physician or health department would say. So I think that's why I like public health nursing so much. I like that independent practice part. So I wanted to just showcase a recent publication here, the Population-Based Public Health Clinical Manual, and that is, again, now a dissemination of evidence. I belong to a group called the Henry Street Consortium, and that was originally funded by a grant that Linda Olson-Keller received through the Minnesota Department of Health. And so we came together as public health nurses and nurse educators, all in the metro area, and developed 11 competencies for students and new public health nurses to kind of guide what they need to learn and focus on. So the 11 competencies are listed there, and we use these competencies to frame our book, okay? And so this book pulls together evidence from the literature and evidence from expert nurses. So each of the chapters, we brought expert public health nurses together to brainstorm about what should be in the chapter, what is the evidence. And so this just came out, April 2011. And we now use it at Bethel, and a number of schools are using it also. This was published by Sigma Theta Tau International. And we're now working on an instructor guide. So that's one of the projects I've been working on during my university professor tenure also. That should be coming out soon, I think. Now I would like to, I'm giving you kind of an overview of the things that I've been working on during my university professor time. One of the things I've been able to do is partner with my colleagues in Norway on several writing projects. And one of them is on the Cornerstones of public health nursing in Norway. So when we were doing the US public health nursing cornerstones, I wondered, are these universal values? You know, how would these guide nurses in other countries? And so I posed this to my Norwegian colleagues, and lo and behold, we're off on a project. And so I'll tell you a little bit about that in a minute. And then the second project, again with Kari Gorbeen, is comparing the Well Child Clinic services in Norway with the Nurse Family Partnership Program here in the United States. So here's the Cornerstone comparison. We are looking at the literature, looked at anything we could find that had values and beliefs about Norwegian public health nursing. So they have guidelines, they have government reports, there are Norwegian nursing articles, there are English articles about Norwegian nursing practice. You can guess who looked at the English literature. So my Norwegian colleagues, my 3 Norwegian colleagues, then conducted focus groups in Norway. We worked together on the methodology. Skype has been wonderful for, really furthering this research. And then my colleague Kari was here for a whole month in October, so we had really an opportunity to work together intensely. So they conducted focus groups with 3 different groups: family nurses, school nurses, and then also home health nurses. And the first group they did was to just explore with them what their beliefs and values were. And then the second group was to bring in the US Cornerstones and say, is this similar or different? What do you think about these? So we're really in the process of analysis right now on that. But from the literature review, I thought I'd share several observations about the similarities and the differences. So how are we similar in terms of public health nursing beliefs and values in Norway and the United States? First of all, in Norway, they also focus on population health. They have a holistic approach. All kinds of, all things contribute to health. Your socioeconomic status, your spiritual well-being, your psychosocial well-being. It's not just physical, it's all those pieces together. Collaboration is important, and also they have independent practice based on their governmental authority. What are the differences then? And this is based on the literature. In Norway, public health nurses focus on the younger population, so that's very different. They work with health promotion, disease prevention for children, parents, teens, and young adults, and they don't include elderly. Okay. So, and education is different too. Public health nurses in Norway have a 1-year certification program full-time following the baccalaureate education. And so the home health nurses only have the baccalaureate education, so that's a little bit different. So what's different? That was one thing, and then the second thing is that there's a much stronger emphasis on the government being responsible for reducing the health inequities that exist. They want resources to be distributed fairly because they do have universal access for healthcare. So that is a much bigger emphasis there. And the literature indicated that they have a greater emphasis on empowering individuals and families to manage their healthcare too. Okay, so we're continuing the analysis on that, and Kari and I will be submitting an article, and my other 2 colleagues there. So then the second project we've been working on is comparing the Well Child Clinic services in Norway with the Nurse Family Partnership Program in the United States. So how are they different? First of all, in Norway, healthcare is universal for all kids, parents, and families. They get a visit 2 weeks after the child's birth. Everybody gets that. And then they have 12 to 15 visits at the clinic prior to school. The Norwegian law mandates that children be seen by a healthcare provider. They don't mandate the clinic visits. So they go into the clinic. However, 99% of the population goes to the clinics. So it's just about universal. And then the nurse-family partnership, not universal. It's only for a very specific population. It's voluntary. It targets specifically low-income, first-time, unmarried moms. And it's not in every state. We do have it in Minnesota. And it's a very intensive home visiting program. So it starts out weekly and may go to biweekly and monthly. But up to 2 years of age, the kids are followed. So just a little bit about what the nurses do. They are very well educated and they get amazing supervision. So they're always talking about their visits with the supervisor. But they focus on things like prenatal health, child nutrition. They look at their social support networks, helping the moms make goals for education and connecting them to community resources. So it really makes a difference in the lives of the people that are involved. So what are we going to do with our paper? We're going to do a discussion paper. And when we look at the evidence, this is Kari's whole premise for wanting to do this study or this analysis, is that they really don't have evidence of the effectiveness of this in Norway because it's universal. It just happens. Everybody does it. And I think she's concerned that it could go away or could change. And so she wants some evidence. So when we look at the evidence of the Nurse-Family Partnership Program, it's very effective. They have the highest level of evidence, which is randomized controlled trials. They've been following cohorts of kids up, they're now in their adolescence, and they have some wonderful results. The kids have higher achievement in school, they have less substance use, they have fewer mental health problems, the families are less dependent on welfare. So there are just many, many, many good outcomes, way, more than that, but I'll just highlight those. So it really supports early intervention using public health nurses. So Kari and I are doing an extensive literature search, especially on the nurse-family partnership outcomes. And when she was here, we crossed the state to do interviews with public health nurse experts. So we were in 4 different counties, and we also interviewed the regional coordinator and the state public health nurse consultant. And so our paper will really focus on what are the policy implications for maternal child health policy and trying to make the case for this is an effective policy for Norway. Okay, so that's my Norwegian work. And then back here in the United States, I've been working with Linda Olsen-Keller on a couple of articles. In 2008, she did a couple of surveys for the Association of the State and Territorial Directors of Nursing, who are very interested in the workforce, the public health nursing workforce. So let's, the idea was to find out the scope of practice of public health nurses. What are they doing it? What are they doing? And then the second article is where I'm more involved with the qualitative analysis. And we hope to publish that in public health nursing. The first article we're going to submit to American Journal of Public Health. That's almost done. It's very close, except Linda keeps leaving the country, so it's hard to finish. Then I'm going to leave the country, so that's our biggest challenge. For the task analysis, it involved 60 nurses representing 29 states. They were all staff nurses in public health. They had at least 3 years of experience. They worked for government agencies, and they took 2 online surveys, both qualitative and quantitative questions. There were 60 in the first survey, 49 in the second. They were primarily women, white, and in the age range of 41 to 61. So this is just a map of the U.S. showing where our sample came from. And this is one figure we're going to use in the article. And then this table shows the comparison of what public health nurses are doing between small health departments who serve a population under 100,000 and large health departments. And you can see here, all nurses do certain things. All nurses do emergency preparedness. All nurses make or receive referrals. The one significant difference, otherwise they were all, there wasn't much difference between the 2 groups, was that in large health departments, not everybody does immunizations. So they're a little bit more specialized in large health departments. But you can see there's quite a large scope of work from all these different activities that they do. This table shows the percentage of time that they spend in each program. And you can see there's quite a range of programs, and so there's a large percentage of time in immunizations, disease prevention, health promotion, and then focusing on family and maternal child health. And then this one shows the essential services. These are actually the standards, performance standards for public health, by which you measure, is public health nursing, or public health doing what it's supposed to be doing? You can see that these nurses function in all these 10 areas of essential services. Public health nurses are the largest discipline in the public health workforce, and I think they're very important to it. So if we lose them, I think we're in trouble. So what our conclusions are, we found that this task analysis shows the breadth and the scope and the complexity of what nurses do. It shows that there's actually a lot of similarity across the country. It shows that there's a large repertoire of skills, a lot of knowledge, and the ability to establish effective relationships came across as pretty important. And we are concerned, we're going to put this in an article, that the decreasing number of public health nurses in the workforce will threaten the ability of public health to do its job. Between 2008 and 2010, there was a 15% drop in the national workforce of public health nurses. That's pretty significant. So on to the qualitative article, which I'm taking the lead authorship on that. And the qualitative question was, for nurses, what would be the impact on the health of the community if there were no public health nursing services? And so the nurses thought there would be more disease and more health problems. There would be worse health. There would be less care for vulnerable populations. There would be negative effects for public health infrastructure, delivering all the services that everybody gets in terms of flu pandemic prevention and all of that. And then negative effects on local health departments. So these are some of the words of the public health nurses, which I think kind of communicate what they see as very important. One said the impact would be devastating. Well, all aspects of public health are important. It is the nurse who pulls all the little pieces together. It is the nurse who looks at the big picture to ensure services are being received. And another one said the biggest impact on the health of the community would be a much less healthy society. And then finally, the most vulnerable among us would suffer immeasurably. That's the quote we'd love to use for the title of our paper. I don't know if the journal editor will let us do it, but we'd like to use that one. Okay, then we also asked about activities that public health nurses thought they couldn't perform that they thought were essential. So we talked about prevention activities, services for older adults and family health services, and things like health teaching, outreach, and home visits. They felt like they would like to do more of that. And here are a couple of comments that our participants made. Even to do a community presentation takes funding that we do not have. Most PHNs that I know pay for many things out of their own pockets to make their presentations more interesting. And that may be similar to the K through 12 educators. You know, I think we hear about that happening. And another one, our caseload is very heavy, and I have to prioritize my cases. So at times, I feel I'm not giving the support and education I could and should to facilitate families I work with. So always that tension between feeling like you're not doing enough, you don't have enough time, but you can see the need, you know, so that is hard. So one of our conclusions is that, you know, public health nurses do work in a challenging, stressful environment, but they believe what they do makes a difference and is important. So that keeps them at it, keeps them going. And then finally, one last set of projects that I'm working on is with Minnesota Nursing Visiting Agency, which is Minnesota Visiting Nurse Agency is the correct title. It's just down the road off of 35. It serves Hennepin County. The program that I'm working with serves Minneapolis. It's the Pregnant and Parenting Teen Program that they have. And so my first article, I worked with 3 staff there, and that article is in press right now, evaluating the program. And then the second article, we just started a research project for that. I'm assuming it's going to be an article, but we just started the research project. And I have 2 grad students working with me, Valerie Curie and Ngozi Mabidi, who's here today. And so Ngozi is interviewing the pregnant teens and parenting teens, and I'm interviewing the public health nurses. I think she's got the harder job to reach the teens. So a little bit about the program. It has 4 kind of pillars or major foci. They also get frequent visits from the public health nurse. And so one of the pieces is the relationship with the public health nurse. Very, very important, foundational. Then the second piece is outreach and coordinating that. So with schools, with healthcare organizations, with employers, and public health nurses are very, very involved in that. And then they have a very specific maternal and mental health curriculum that they develop with special activities and content. And so they deliver that at each visit. And then the fourth part is the support they get from the community. They have an organization called Club 100, which is with people from the community who donate all of these items that you need to raise children that all of us just buy when we need them. And here they can't afford them. They have very little money. And so the nurses will bring these items out to the moms. And so they feel very supported by the community. So when we look at then the evaluation, we worked with data that had been collected and analyzed by Wilder Research. So we had a report to work from. We were making frequent calls back to Wilder to say, is that what you meant? What does this mean? In order to make it clear for the article. But I worked with 3 staff to do that. And you can see it's a highly diverse population, African American, Hispanic, well represented, average age of close to 17, but from very young up through 19. And then the average number of visits per participant were 19. And then we had a number of outcomes. I don't think I will read each one, but you can see that they're pretty good. When you think about Minneapolis and all the pregnant and parenting teens, this program reached 77% were referred, and 78% of those referred accepted services. So that's quite a large sample. And they had a healthier birth weight, and people who had more visits continued in school longer or graduated. So there were really some good outcomes. They got referrals, they received Club 100 items, they were up to date on immunizations. So all really good stuff. So, and that article is in press. And then the current project is a really long research question, but basically it looks at what do public health nurses that are work in this program and the teams that participate, what do they think is important about the mentorship relationship that helps the teens be successful in their parenting, their sense of well-being, that kind of thing. And so we're doing interviews, and the participants need to be in the program at least 6 months and age 16 or over. Just we thought we'd put that limit, even though there's younger people in, because they would be better able to talk about it and articulate it. So far, I've done 3 public health nursing interviews and have 2 more scheduled and hope to get a couple more. But one thing that really came through in those interviews, what the point was that cut across all of them, was that the nurse was non-judgmental about working with the teens. And I just, this really resonated with me in chapel yesterday when we heard from Reverend Gloria Thomas talking about the lessons that she learned for working with vulnerable populations. And the first one was, do not judge, being non-judgmental. That contributed to her success. And so I think that's one lesson that we'll learn from the public health nurses. That was emphasized over and over. But we'll have more to figure out, so that one's yet to come. And so what's next is my Fulbright Specialist trip to New Zealand. I'll leave March 8th, so after I get done with this presentation, I got to get ready for more in New Zealand. And I'll be at Auckland, University of Auckland, doing consulting on public health nursing education and some presentations on the public health intervention wheel. That's my doorway there. And also advanced care planning. I'll be meeting with both academic and community professional groups. It'll be a wonderful opportunity for me to learn about the Maori culture. Now, you may ask, how did I get to New Zealand other than the intervention wheel? Well, this is always an interesting story. It points to, how important it is to collaborate. In 2002, I went to University of Nebraska, in Lincoln, Nebraska, for a ethics seminar. And it was from all disciplines. Well, ethics seminar was a woman named Jennifer Hand, who worked in public health in New Zealand. And so we started talking and continued, communication via email. And she had a colleague, Nikki Sheridan, who wanted to come to Minnesota to learn about the public health intervention wheel and apply it to New Zealand. So Nikki came in 2003, and I hosted her. We did some fun things like go see Taliesin because she had been an architect major the first time. So we did some fun things like that, but really focused on learning about the public health intervention wheel because she needed to complete a dissertation. And at that time, she invited me to come to New Zealand. Well, I couldn't figure out a way to get there for a while, but I did now, so I'm going to go. And it's just such a blessing to have this opportunity, how these things come together. And you never know what doors God will open, but just being open and willing and getting out of my comfort zone was kind of important to help make that happen. So this is a summary of what it takes to build an evidence base for public health nursing. One must collaborate, one must always be involved in education, one must disseminate. What this has involved for me, characteristics of persistence, okay? I think on average, I revise 2 to 3 times an article. My article on my dissertation research was 6 times. So you have to be persistent, you just have to. You have to devote time, you have to give time to it. And you have to, follow that rigorous writing process that doesn't involve your ego. Because if it does, you're lost. You just have to let go of that ego. It involves being willing to move out of one's comfort zone. I've needed to do that. Here I am in Norway in 2005 on a Fulbright. I had never lived alone before. So, getting out of one's comfort zone. And then just being willing to link to opportunities and people that inspire and are fun to work with. Find those people and work with them. And I'm just very grateful for the mentorship I've had along the way, and I also am just totally enjoying the mentorship opportunities I have with my colleagues and with my students. So, and I'm just very thankful to Bethel University for giving me this opportunity, this time, and this trust to do this work. So I'm thankful for that. Thank you. Oh, if you need to leave, go ahead. If you have a question or comment, I think we have maybe 1 or 2 minutes.
Sounds like the population of public health nurses is similar to the population of public school teachers in terms of ethnicity.
Yes.
Is there any push to recruit more nurses of color?
Yes. Yes, there is. I mean, that's a great question. That's something when we look at the population of public health nurses, anytime we can recruit someone from an ethnic minority, we just celebrate. But it is hard. It is hard. Yeah.
Why have the numbers gone down overall?
Oh, for public health nurses, it's because of the budget cuts. Yeah, so they're cutting positions or they're not rehiring when they open up. Yeah, that's the reality. Well, how are you going to spread out the money? Lose nurses. Yeah, but we need to show, nurses need to show what they do so we don't lose them. Yeah. And the other thing is sometimes other disciplines, they think maybe other disciplines can cover what public health nurses have done, and that doesn't work always so well either. Yeah. Okay, anything else? Well, you've been a wonderful audience. Thank you for your support. Make sure you help yourself to some healthy food choices. Okay, have a great day. Bye-bye.